Yes. Hello, good morning. I'm Manuel Rovira. I'm one of the nephrology fellows, and I'll be talking about Hep C viremic kidney transplantation into aviremic recipients. Before we continue, I would like everyone to imagine an ESRD patient you're taking care of, and a Hep C positive kidney becomes available. Would you recommend it? If your answer was no, I expect to change your mind by the end of this presentation. And we'll talk about history and epidemiology, treatment and outcomes, clinical implication, and future studies. About Hep C virus, about 1% of the world's population is infected with Hep C. It's one of the top leading causes of death. And about 400,000 deaths occur due to Hep C. And this number has been downtrending due to available treatments. Other history about Hep C. It was first discovered in 1989 by Michael Hutton. And the first Hep C transmission from organ transplantation was reported in 1991 from a 1976 serum recipient sample. Eventually, patients were treated with interferon. This was poorly tolerated due to anemia and low cure rates of about like 30%. And Hep C donors were considered infected as infection was determined by Hep C seropositive and no RNA. And previous standard of care was limited from Hep C infected organs to Hep C infected recipients. And too often, those organs were discarded as well. At that time, Hep C infection has been associated with worse graft and outcomes, all this prior to direct-acting antivirals, which came more into treatment about 2015. Before the DAAs, there was no effective treatment. Eventually, in 2020, Michael Hutton and team had the Nobel Prize in Medicine. We can start looking at the trend of viremic kidney donors, which we can see in this figure. The number of viremic donors has increased up to 2020, and nowadays constitute about 10% of donors. So what about transplanted kidneys? So the kidney transplantation from Hep C viremic donors has been increasing since 2015. So before, as we said, the standard practice was more from Hep C positive to Hep C positive. But nowadays it's transplanted to Hep C negative recipients. Well, you can think about and how many offers have been made. And this figure shows Hep C viremic offers from 2015 to 2019. It's an underused resource as most centers did not perform transplant from Hep C viremic donors. It's a trend that is currently changing. As of June in 2020, 42% of centers did not offer Hep C viremic organs to aviremic recipients. And this led to an increased organ discard. And most of these organs came from young individuals, otherwise healthy. In the next slide, we'll see how many Hep C viremic kidney organs were transplanted as of 2019. And as we can see, it was more of a practice in the East Coast. However, nowadays, more and more centers are doing a kidney transplant from Hep C viremic into aviremic, including University of Washington as of June of 2023. We can talk about how many have been discarded. And this data covers 15 months from the beginning of 2018 to March of 2019. And it showed how many viremic kidneys were discarded by region. A total of 677 kidneys were discarded, and this is about like 39% of the kidneys. And now we'll talk about some trials. And I'll talk about 4 trials, one that's divided in 2, which is Thinker 1 and Thinker 2, Expander. I'll talk after Mythic, and then we'll leave Dapper to the end, and we'll go into that. For the Thinker, it is Thinker 1 and 2 because Thinker 1 happened in 2016 with 10 patients and Thinker 2 in 2017 with 10 patients. It was the first small trial by Peter Rees. It was an open label and single group pilot trial done at UPenn. So we said included 20 Aviremic recipients with a genotype 1 donor. For Hep C, the genotype can go from 1 to 4. And this is relevant because it's treatment dependent. And then in this case, they were giving genotype 1 treatment once they detect viremia in the patients, and all the patients detect viremia by day 3. And their outcomes was a sustained virological response at 12 weeks, which all of the patients were able to achieve. And so a sustained virological response at 12 weeks means that after the last dose of treatment, 12 weeks after that, they assess for the virus and they have no viral level. Next, we'll go into Expander. In this study from 2018, was an open label, non-randomized trial. It used, or the population was 10 Aviremic recipients with genotype 1 to 3. And they started treatment immediately prior to transplant and continue it for 12 weeks. And they also sustained virological response at 12 weeks with no adverse events. For the Mythic trial, it was done in 2022. It was a open label, single arm, 7 sites, including UPenn, Johns Hopkins, and Mass General, University of Cincinnati, Michigan, Cornell, and Northwestern. And in this case, it was 30 Aviremic recipients with pan-genotypic viremic donors. It was a pan-genotypic treatment. It was started 3 days post-transplant, regardless of their viral status, and it was continued for 8 weeks. In this case, it was compared to 2,000 matched competitors. On all of them sustained a virological response at 12 weeks with no adverse events again. The 1-year graft function was excellent, and we'll talk about the probability of transplant in the next slide. For those patients who enrolled in the trial and received a viremic kidney, they had a 1-year cumulative incident of kidney transplant of about 3.5 times greater than those who not opt in to receive a Hep C viremic kidney. In terms of treatment, we can talk about the current recommendations by the American Association of the Study of Liver Disease and the Infectious Disease Society of America, which recommend a pan-genotypic treatment, either by 8 or 12 weeks, depending on the treatment itself. And questions have been brought to see if treatment can be shortened. Some say it is to reduce costs, because before treatment was about 50,000 for 12 weeks, and nowadays it's about 13,000 for 12 weeks. Some say to improve adherence, even though this hasn't been much of a problem. Some studies have trial empiric treatment before or early after transplantation. And that's where the DAPPER trial comes in, which we'll talk next. The DAPPER trial was done in 2020. It was an open label, non-randomized, single-center trial. It was done at Virginia Commonwealth, and it consisted of two groups. Group 1, which is 10 recipients, and Group 2, which is 40 recipients, both of them Aviremic, and receive genotypes 1 to 3. And they compare giving treatment 6 hours before and just 1 day after for Group 1, or 6 hours before and continue for 4 days for Group 2. And what they found is for the first group, 30% of patients develop viremia and eventually require full treatment. And for the second group, about 7.5% develop viremia and require full treatment. All of the patients sustain virological response after receiving full treatment. Their argument was that patients had a low transmission rate. However, potential for resistant mutations are concerning. So what about timing of therapy initiation? I think the ideal treatment based on the trials would be a pre-transplant dose and continued treatment early post-transplant. Some have experience with starting treatment about 2.5 months after transplant. However, significant side effects of delayed treatment, defined as more than 4 weeks, has shown complications, especially fibrosing cholestatic hepatitis in about 3% of patients. And that's a rapid inflammation, cholestasis, hepatocyte ballooning, and advanced fibrosis. It is resolved after DAAs. However, it is a risk the patient is exposed to, and it's not aligned with the patient's concerns of transmission, as we'll go into. And some of the caveat of this ideal treatment are insurance approval, which can sometimes take weeks, and medication might not be in hospital formulary. So what about post-transplant challenges and outcomes? In this survey from 2020, it included 69% of those transplant recipients in 2019, and 54% of US transplant program. And we'll talk about some of the patient and provider concerns. In this figure, the top 3 patient concerns were high out-of-pocket cost of treatment, fear of infection, treatment failure, and then household transmission. For the providers, it was about insurance coverage for treatment, high treatment cost, and then risk of transmitting resistant Hep C. And interesting, a fear of harming recipient was one of the concerns. And if we assess Hep C viremic donors based on the KDPI, which is a scale that goes from 1, which is the best, to 100 being the worst, is a measurement some transplant centers use. The higher the KDPI, the lower the quality and shorter expectant longevity of the organ. Current formula does not distinguish Hep C seropositive but aviremic versus a Hep C viremic. With those Hep C positive but aviremic, they carry a negligible Hep C transmission risk. And then comparing to a Hep C viremic, which carries around 100% risk of transmission without therapy. In this case, when the standard KDPI was used, none of the 207 Hep C aviremic kidneys had a score less than 20, and 7 had a score more than 85. And when the modified KDPI for the aviremic kidneys was used, 63% of those kidneys had a KDPI less than 20, and no kidneys were above 85. And this is to give an idea that the current KDPI might not be such a good assessment for organ quality. Um, and currently, the Hep C is defined as either having Hep C seropositive, nucleic acid, or both. And being Hep C positive provides about a 20% increase in KDPI. What about the allograft survival? So this graph is a 5-year allograft survival from 2016 to 2021, and they compare 2,500 Viremic donors with 43,000 Aviremic donors, and data was gathered from 217 centers, and we can see the allograft survival is essentially the same as Aviremic donors. In terms of cost effective, based on this simulation study from 2020, when they took the US patients who were currently on HD and on waiting list, they used a simulation and they look into quality of life and cost effectiveness once receiving a Hep C viremic kidney with treatment versus Aviremic. And it showed that accepting a Hep C viremic kidney resulted in increased quality adjusted life expectancy and reduced healthcare costs. A quality adjusted life expectancy is a value change in treatment times the length of it. For example, a QAL of 1 is a 1 year of perfect health, and in this case was 0.91. And cost saving was about 190,000 per patient. From an economical standpoint, it was cost effective as long as it was done less than 3 years. However, this doesn't take into account the quality of life improvement in the patient, which includes reduced waiting time and time on dialysis. So some clinical implications are patient education and assessment, which most Hep C donors are young. Hep C is treatable, safe and cost effective, and kidney allograft, as we said, 5 years is similar. Revise KDPI to consider Hep C viremic versus aviremic. There's potential for decreased KDPI with aviremic and hence decrease discard rates in otherwise healthy organs. And KDPI does not differentiate between Hep C status and provides about a 20% increase if positive. And treatment are so effective that for Hep C that might be possible to remove from KDPI. And timing to start and length of therapy, either empiric versus RNA-based, ideally should be treated empirically with the pre-transplant dose and an early post-transplant. Hep C genotype might be important depending on the treatment use due to medication resistance. And some other implications might be in patient medication availability and insurance coverage. And further studies will be focusing on long-term outcomes, quality, kidney quality reassessment, patient and physician education, immunological complications of acute Hep C, and best course of therapy. There's also an ongoing phase 4 trial at Johns Hopkins with 10 participants, and the treatment includes a pan-genotypic treatment given in the OR and then continued for 2 weeks. So we're looking forward for that. Now, after this presentation, I hope I convince you about recommending Hep C positive donors. So I would like to express my gratitude towards my mentor and other division faculty who guided me and made this presentation possible. I'll take further questions now.
Thanks so much, Manny. Questions for Manny? I was curious about if you know anything about the kind of how patients are talked to about this, if they're kind of how to frame a consent. And maybe you're familiar or others on the call, but clearly a complex question to pose for patients.
Yes, it is complex, and actually there have been studies about when will be appropriate to approach these patients, and one of them actually included to be more appropriate when there was a change, either from a non-active to an active wait list, or when doing a visit assessment, rather than kind of like calling them on the spot, which they can feel a bit pressure about it. But yes, there have been studies about what questions specifically to ask. But the most relevant, we'll say, like when to assess, and it's either when there's a change in status, um, or when there's like a full visit as well.
Mhm.
Any other questions?
Manny, do we know if there's if we're starting to look at doing this for any other viruses like Hep B or even HIV, you know, recognizing that that's a lot more complex because it requires treatment for life, but
I do not yet, but as you said, I'll probably look forward for that as well.
Thanks, Manny. I'm curious, in the early trials, were there any major exclusion criteria that excluded a big portion of patients that we should know about?
Mostly liver cirrhosis was one of the main one of the main ones to be excluded for. I think that would be almost like every of them excluded that ones, and then less than 18-year-olds most of the time as well.
It's striking. It seems like issues with the KDPI come up in a lot of different contexts, and we're relying on this metric that had been developed in a much earlier population when things have changed so much. Yeah. It's striking how much it would change the kind of profiles with this this one shift.
As we said, that KDPI was developed when there was no effective treatment for Hep C as well. So.
Well, if no further questions, appreciate your talk. Thank you so much, Manny.
All right, thank you.
We'll move on to our next speaker.